our last talk of this afternoon session. Dr. Jordan Stern from Stanford is going to present the unique failure modes and complications of iliac branch devices. Go ahead, Dr. Stern.
Hello, I'm Jordan Stern. I'm a vascular surgeon at Stanford University. Thank you very much to the VESS for allowing us to present our work on the unique complications and failure modes of iliac branch devices. We have no relevant disclosures. Up to 1/3 of abdominal aortic aneurysms are associated with concomitant aneurysms of the iliac vessels. When considering an endovascular approach to combined aortoiliac aneurysmal disease, there are several potential strategies. If no suitable landing zone exists in the common iliac artery, one approach is to embolize the internal iliac and extend the graft into the external iliac. This is the so-called coil and cover strategy. Other strategies aim to maintain flow to the hypogastric artery. These include the use of flared or bell-bottom limbs, parallel grafting techniques, and more recently, the use of dedicated iliac branch devices. Preservation of hypogastric blood flow is desirable for several reasons. Occlusion of the hypogastric artery can lead to buttock claudication, sexual dysfunction, and in rare cases, even frank pelvic ischemia. The internal iliac is also an important collateral pathway to the spinal cord, which is important for those patients undergoing more extensive repairs and at risk of spinal ischemia. While flared limbs are available in diameters up to 28 millimeters, their placement in ectatic or aneurysmal iliac arteries can lead to long-term complications such as type 1b endoleak. Additional issues arise with the use of parallel grafting strategies as well, such as gutter leaks. Iliac branch devices, or IBDs, are bifurcated grafts designed to be used in conjunction with standard EVAR. The hypogastric branch is generally cannulated from the contralateral femoral artery, and the two limbs are extended into the internal and external iliacs respectively. Currently, the Gore iliac branch excluder, or IBE, is the only available device in the United States, though the Cook Zenith branch and the Yotec device are available elsewhere. Iliac branch devices, while extremely useful for preserving hypogastric flow during EVAR, are not without their own potential issues. Technical failure may occur when the hypogastric artery cannot be cannulated and stented. Occlusion of the hypogastric branch may occur as well, leading to the issues previously discussed related to reduction in pelvic blood flow. Finally, there is a potential for separation of the IBD from the main EVAR, leading to type 3 endoleak. This study aimed to identify outcomes of our large series of iliac branch implants and identify those patients who experience these unique complications. We then sought to identify any underlying factors associated with these. We retrospectively reviewed all patients undergoing iliac branch repair between 2014 and 2019. This includes both Gore IBE devices implanted after FDA approval in 2016, as well as both the Cook and Gore devices during clinical trial enrollment and continuing access. We identified 59 patients having 64 devices implanted. 5 patients underwent bilateral repair. There were 59 Gore IBE implants and 5 Cook devices. Patients had the expected range of comorbid conditions. Also expectedly, there was a high rate of associated aortic aneurysm, and 14 patients were treated for iliac degeneration following prior placement of EVAR with a bell-bottom limb. Nearly 10% also had an associated internal iliac artery aneurysm. Technical success, defined as the ability to deploy the graft, cannulate the artery, and deploy the hypogastric branch, was achieved in 93.8% of cases. Other perioperative values are displayed here, reflective of the complex nature of these repairs, especially early on in our experience. Overall, there were 0 mortalities noted within the first 30 days. Early reintervention occurred in 5 patients, with 3 cases of branch or stent occlusion, 1 femoral pseudoaneurysm from an access complication, and 1 unfortunate case of a thoracic aortic wire perforation requiring TEVAR. 4 patients experienced buttock claudication. 2 of these were in cases of hypogastric occlusion, and the other 2 in patients with patent internal branches but who had undergone embolization on the contralateral side. Overall, hypogastric occlusion occurred in 4 patients, all within the first 30 days. 2 of these were asymptomatic and no intervention was undertaken. The other 2 were intervened upon for buttock claudication, as previously noted, and successfully reopened with resolution of symptoms. 5 patients had separation of the IBD and main body device, 3 intraoperatively and 2 on late follow-up. All of these patients were successfully treated with the addition of additional bridging components, either at the time of repair or as noted on follow-up. In an attempt to identify predictive factors of these complications, we looked at a number of anatomic and graft-related variables. This includes prior EVAR, the type of graft implanted, common external and internal diameters, tortuosity of the aortoiliac segment and the iliac artery itself, as well as the use of a reverse locking technique for the bridging component. Technical failure was only associated with prior EVAR with a p-value of 0.04. Separation of components appeared to be primarily related to tortuosity, both of the entire aortoiliac segment as well as the iliac artery itself. Larger internal iliac components were also predictive of this adverse outcome. We did not identify any specific factors associated with hypogastric branch occlusion. While we were able to achieve a high rate of technical success and overall favorable outcomes, these IBD-specific complications do warrant attention. Technical failure was more common in patients undergoing IBD in the setting of prior EVAR. This is not surprising since the steep flow divider precludes normal cannulation from the contralateral side. While we have generally approached this situation by using arm access to deliver the hypogastric component, we have more recently successfully used steerable sheaths to allow cannulation either over the flow divider or via the ipsilateral femoral artery as shown. Occlusion of the hypogastric branch occurs infrequently, and some of these patients may be asymptomatic. In these cases, there is no need to attempt recanalization. When patients do present with symptoms and an occlusion is noted, the stent can potentially be reopened using a variety of endovascular techniques. Finally, separation of components can represent a dangerous situation if there is a type 3 endoleak with ongoing sac pressurization and growth. This appears to be associated with tortuosity, so in cases of tortuous anatomy, some additional measures should be considered. The stiff wires should be removed prior to the final angiogram to allow the components to settle into their new configuration. This may reveal a problem while still in the operating room, having a chance to correct it. In these situations, additional components can be considered to lock the system in place. In summary, IBDs are extremely valuable and our preferred method for maintaining hypogastric flow in the setting of aortoiliac aneurysmal disease. As our experience has grown, a high technical success rate is achievable, though some complications may still occur. Prior EVAR and tortuous anatomy appear to be particularly associated with problems, and so IBDs should be carefully planned and considered in these situations. Thank you very much for your attention.
Well, I think I'm a little bit biased, but having said that, excellent job, Dr. Stern and Dr. Lee. Congratulations on your excellent series. Jordan, I have a couple of questions. The first one, on the patients that you had separation of the main body from the IBD, any tips that you can give us to prevent this?
Yeah, thanks a lot for the question, Manuel, and I appreciate your biases here. You know, it's interesting. You know, the seemed to be more tortuous anatomy was associated with that complication, and actually, of those 5 patients, one early and late separation was the same patient, and so I think in retrospect, this is somewhat predictable when you see very tortuous or large aneurysms. So there's a couple of techniques. I mentioned one, which is removing the stiff wires prior to the final angiogram. You can actually also deploy the IBE over a softer wire like a Benson or even a Rosen wire to allow it to deploy actually into that sort of more native configuration rather than in a more stiff one confined by the Lunderquist wire. The other thing to do is, I think, try to really maximize your overlap. If you know the IBE device especially, they have the markers that sort of indicate where the maximum and minimum overlap is. And I think in cases where you might be worried about component separation, really trying to maximize that overlap is probably prudent. And, you know, if you're concerned about length, then using perhaps an additional limb to sort of lengthen before you put the bell bottom in to lock with the IBE might be one solution to sort of to get over that problem and allow more overlap, so that even if there is some pulling apart, then you haven't really pulled all the way apart to lead to a type 3.
And on the patients that you're concerned of, because anatomical variance or complexity of graft patency, do you anticoagulate, give dual antiplatelet, or you just wait and see?
Yeah, I think it varies a little bit by operator. There's certainly no standard. My practice is generally just to use aspirin for the hypogastric branch. I wouldn't do dual antiplatelet therapy myself, like I would do generally for 6 weeks following FEVAR, for example. But I think that's a little bit dealer's choice. I think if you think it might be particularly tenuous and, for example, the contralateral hypo is occluded and you really want to maintain that flow, then maybe a 6 weeks or a couple months of dual antiplatelet may be prudent.
We have a couple of questions from the audience. The first one from Jill Sink. Can you elaborate on the techniques you use for opening the occluded hypogastric artery?
Yeah, so my personal preference is to use a suction thrombectomy like a penumbra, but often the hypogastric branch can actually just be crossed and reballooned or just relined, depending on sort of how deep you've gone into the hypogastric and where the branches are. Sometimes you can sort of just balloon this and reline with maybe a self-expanding stent if you're worried about some kinking issues or things like that. But I think that mechanical thrombectomy like the penumbra device, for example, it's pretty flexible and allows you to get into that stent and actually clear some of the thrombus as well.
A question from our president, Dr. Corrier. What caused the wire perforation requiring a TVAR? Was it avoidable, and did it occur late or early in the case?
Can you just repeat the first part of the question? I'm sorry.
Yeah. What caused the wire perforation requiring TVAR?
Oh, yeah. So that was actually a patient that was a little bit more complex that had a chronic dissection. And so the wire, it was just an unfortunate thing where it kind of meandered a little bit. I think that when you're doing iliac branch, you're actually sort of much lower than you are with standard EVAR. And so the wire doesn't necessarily need to be as high. So I think if you're worried about some thoracic aortic pathology, then you can actually sort of keep the wires a little bit further down. But, I think that everybody's sort of had wire misadventures at times, and it's just sort of one of those unfortunate things that happen.
Another question from Karen Garg. Any of these separations involve a VBX or the conventional IVE component?
So good question. The separation was actually between the main body of the iliac branch and the limb of the EVAR. So we didn't actually have any device separations between the hypogastric component and the IBE itself. I think that either way, whether you're using a VBX or the dedicated hypogastric limb, you're at some risk of this. Although I think that in the pelvis, it's somewhat more fixed in nature than it is when you're talking about a big aortic aneurysm, and so probably a little bit less likely. And we didn't actually find that particular separation in ours.
Jordan, if you have a patient that requires bilateral iliac branch devices, do you, consider coiling one, or you just go with bilateral? What's your practice?
Yeah, I think it's a little bit dependent on anatomy, but my preference is almost always to branch both sides. I think that, as we've become more adept with this particular technique, doing a bilateral iliac branch is not as technically demanding as it may seem before you've done it. You basically just go up and over through the first one to get into the second one. And to me, the worst thing that happens with these is that the hypogastric branch occludes, and you're sort of then in the situation you would have been anyway with an occluded hypogastric, if you would have coiled it, for example. So my preference is whenever anatomically feasible to do both.
Karen Garg mentions that we have seen type 3s with VBX, just to be aware. And we don't have any more questions. Dr. Humphreys, anything else you want to add?
No, I think this was a great session. I think there's so much to think about, a lot of thought-provoking topics as well. I want to thank all of our speakers and their mentors for being here for the session. I'd like to remind everybody that we'll have the 6th session tomorrow starting at 7 a.m. And at that point, it might have sunk in to me that Dr. Corrier is actually the immediate past president and Dr. Jason Lee is the president. He will be moderating that session tomorrow with Dr. Mark Conrad, who is our treasurer. So we look forward to seeing everybody tomorrow morning at 7 a.m.